saw you hit that button.
Sing that again?
No, I saw you hit that button, turkey.
I thought you said, girl, you're amazing.
Girl, you are amazing.
Are you talking to me?
Yeah.
Come on now. All right, are we ready?
Whenever you are.
Hello and welcome to Slice of Piefer. I'm Dr. Piefer. I am here with the one and only Taylor Hayden.
Howdy.
How are you? Wow,
I'm
Texas
great.
A&M roots coming out there.
Thanks and gig 'em.
Even better. I like it. Well,
Texas Aggie class of 2011.
oh gosh, 10 years after me. Mm-hmm. That's terrible.
Just a tiny, tiny baby.
Just a tiny baby Taylor. Mm-hmm. How's the week?
Good.
Yeah. Mm-hmm. We get to have some fun talk today, I heard.
Fun
Gonna be
talks.
exciting.
Yeah.
Nice.
Typically.
We had a busy week. It felt like. Mm-hmm. A lot of fun cases today.
Yeah.
It's a Friday. This is Fun Friday. Fun Friday afternoon.
Fun cases. And then you also, we saw fun patients during this week, which means some interesting cases next week, too.
Interesting cases coming down the pipe.
Yeah.
Very true. Very true.
You certainly aren't the guy who just does the chip shot cases.
Yes, that is correct. We're going to have some...
Tackle some fun stuff.
Yes, we'll have some good things. Whether it's knees, hips, shoulders, we'll have a lot of fun.
And in this case, and not even just those, maybe a foot.
Oh, yeah, that's true. Yeah. Mm-hmm. Fixing up a midfoot fracture. That's always great.
Mm-hmm. It's going to go superb.
Yeah. She's going to love it.
They're going to love it.
They will. Agreed.
Agreed to agree.
Perfect. What else? What else is new in the Hayden house? Oh, Chrissy and Cameron are in Honduras. So
right.
That's awesome. We talked about that.
That's not happening in the Hayden house, but that's cool for the Piefer house.
Correct. So
just you and the little twos.
Just me and the 16 and 13-year-old.
That's a good time. Do y'all have a party?
We have had some partying, yes.
I imagine it's a lot like the intro to like Mrs. Doubtfire when she comes home and they like Robin Williams' character is holding like a full-on house party. Miranda, what's up? You're home early, girlfriend. Where he's got a donkey in the house.
Yes, that is what it's going to be like, especially when Chrissy gets home tomorrow. Mm-hmm. I have a feeling Caroline she's living her best life. Mm-hmm. She's starting to understand that I'm going to make pretty much most of my responsibility in life is going to be to annoy her. So
mission accomplished. I think you already accomplished that.
I think that the father of a 13-year-old, your primary goal in life is to annoy your 13-year-old. So
Dan would agree with you.
She likes when I sing to her in the car. She really enjoys if I pat her on the shoulder in the car. Mm-hmm. That's a big personal space violation, apparently.
Gotcha.
Yeah.
You know what, though? She will look back on it and she will be so glad that she has those memories because I think about them all the time still when I'm driving with my kids and thinking back to sitting in the passenger seat of my dad's truck while he was singing 90s country and playing the seatbelt guitar while he was driving. Yeah. Nice. And it makes me smile every time. I don't get like, oh, that was so annoying. At the time, I'm sure I did, but
yeah,
some of my favorites.
She definitely has some annoying. She's got some annoying pieces, or she has some tolerance for my annoyance. Mm-hmm. But she and Chrissy, they kind of they run together in that. They feed off each other. Bond. They have a bond of me annoying them, so it's good.
Must be a genetic dominant trait.
Yeah,
passes along through that second X chromosome.
Yes. So it's good.
Yeah.
It's like, hey. But I asked you what was going on with your family, then I rudely overspoke.
You're fine.
All that was happening with me.
Hey, mi casa is su casa. This is your place. This is your cave you've created.
This is the man cave. Well, but what's up with your kiddos? How are they doing? How are the monkeys?
They're great. They're rocking and rolling, getting ready to go hang out in Disney World. So
nice. What are you most excited about for Disney World?
I've just never been, so I'm excited for all of it. I'm excited to see. I grew up watching Disney movies and was obsessed with most of those characters. I wanted to be Belle, like I loved. So I'm excited for all of it. The food and coffee is high on the list of things I'm excited about. But just spending time with them and getting to watch them like enjoy somewhere like that.
Right. And I think if you can do the cool thing for you, having never been, is going to be to try to take a moment to, and you can do it through your kids, but to look at it through the eyes of a kid. Because like the castle and all these crazy things that are so huge and awesome, and like it's just like you don't appreciate it when you're a kid, like how much really had to go in to make this place what it is. And so I think that's kind of a fun side of it, that you'll get to have some of the awe of being a kid there for the first time, but also the understanding of, man, this is pretty amazing what they did. So
yeah,
cool.
I'm excited. Not super excited about the drive, but
when is that? That's in like 2029 that you're going?
No.
It's coming up soon?
Yes.
What?
Yep.
So I'm going to be here by myself?
All by yourself. With also the team. So you'll be fine. And sweet Walter.
Interesting.
You're going to be in great hands. It's going to be fine.
What am I supposed to do with my hands?
Operate.
Ouch. Yeah. All right. Bantering. Terminated.
I like how you're like, this segment of the podcast is complete. The
we have now,
off-the-cuff banter.
We have now completed the section marked banter.
Gosh.
And that will now be followed by feats of strength.
Great strength of feet. What movie is that from?
I don't know.
Robin Hood Men in Tights?
I mean, I do know that movie, but I don't remember that.
Remember when they're in the prison and he's with not a Chew, but a Chew's dad. A Sneeze, maybe? And he's like, what we need is great strengths of feet. And they kick the bar to get out of the prison.
I do not remember.
What?
Yeah. I mean, I do like the Robin Hood Men in Tights. That's a good movie.
Such a good movie. And so much better when you're an adult and you rewatch it and realize all the stuff you missed.
All the different things. Yes. It's
going
to be like Disney.
Probably so.
Yeah.
A lot like Disney.
Are you going to wear tights to Disney?
No.
And Dan?
No. Doubtful. It's hot.
I think Dan should be a man in tights at Disney.
He's going to be a merman.
Dad, what are you dressing up like? Merman.
Yeah. No, I ordered like a couple of like funny shirts and stuff like that for them to wear. So we'll see.
Yeah. Chrissy had a shirt for me that said, I'm here for the snacks.
Nice. Dad tax.
Yes.
Yeah. I don't think I ordered him anything like that. I ordered him a Donald Duck one where he's like grumpy and it says, this is my happy face.
Nice.
Which
That's a
fits
good one.
Dan really well.
You need to get him some like 1980s short shorts and some long socks that go up to his knees. Then that way.
I like him. I don't want to torture him.
No, that would be great.
No.
Yes.
We won't do that to the Danimal. That's not nice. Crickets. All right.
What are we talking about today, Taylor?
So
we are talking about fun stuff. I only read the first sentence.
Wow. Just like you. You know, it's not like you, because most of the time when it comes to cases, like you're so prepared and you've reviewed imaging and you've looked at the office notes to know more about the patient. You've talked to the patient. Like you've done all this stuff. And then you walk in here and you're like, I didn't read anything. I read the first sentence.
This is my happy place.
Yeah. So if I mention the phrase, the SCAR rule, do you know what I'm talking about?
I do know what you're talking about, the SCAR.
Well, you should, since it's something that you talk about.
I talk about, right?
Correct.
So even the best of the best, no surgeon can leave without leaving a mark, right? Mm-hmm. And so there always will be a memory of what you've done and where you've been. Even if the outcome is absolutely perfect, people will always know that you were there. So you should do everything you can to have the best possible outcome, but also understand that you also need to leave the best possible mark behind.
Mm-hmm. Yeah.
And
so in thinking about that, thinking about like the marks we leave behind, the cases that we do, is there a case, or I know there are, but I was thinking through some of the cases we've done together, and cases that we still think about, and not necessarily because of like the great things that we did, like the ones that were like slam dunks. We walked out of there like with our heads held high. I'm like, that was awesome. Sure. I'm talking more about the cases where that's one that shows up in your mind. I don't want to use the word haunt, but it's something that you still think about, that didn't go the way that maybe we hoped, or
sure,
case that didn't go the way that we planned for.
Yeah. I mean, one of the things about orthopedics and surgery in general is cases don't always go the way you plan them, right? Mm-hmm. And you have plan A, you have plan B, you have backups, and you end up in a situation where what you're trying to do in terms of getting a reduction of a fracture or getting something put where it needs to be doesn't work exactly how you want it to. And so that certainly is, I mean, I think we end up moving to plan B, especially when you're on call, especially when you don't have as much control and as much ability to plan ahead. You end up in those scenarios pretty regularly. I mean, where you've got to do something else, something different than what you thought.
Sure. And like one that comes to mind for me, and none of these cases are ones that are going to be recent. These are all ones. I mean, I've been working with you since 2017. So we're going to hark back to some oldies.
Harken back to the oldies.
But I'm not going to have to talk much for you to know exactly the one I'm talking about.
Okay.
To start off the bat.
Hold on. I'm ready.
Okay. So we had a patient who came to see us.
It was a dark and stormy night.
No, it wasn't. But we were operating into the night for this nighttime specific one.
Got it.
So this person actually came into the outpatient clinic and had a phlegmon, or looked like an abscess on their shoulder. Had a history of a previous cuff repair done by somebody else. And we were hoping, and looked at imaging, ordered a CT and all this stuff, hoping that it was just a contained abscess in the superficial tissues. From there, they had been trying to inject themselves, and they had been trying to aspirate themselves.
Correct, yes.
And we were really worried about that, but we got the CT and things looked okay. And then we got in there and it was pus all throughout that shoulder, right? In where those, you know, on routine CT scans where someone's have a cuff repair and they have anchors put in, you can see those cysts that form around the anchors. And so we were hoping that's all it was. But when we got in there, it was clear that this person had osteomyelitis now of the shoulder.
Correct.
So
yes,
that was one that definitely didn't go as we had hoped, right? Or necessarily what we had planned for. We were hoping it was going to be a pretty simple, open it up, drain the pus out, clean them out, and move along with our day. And then it ended up being that he had seeded his previous shoulder surgery and ended up with a massive infection.
Right. Yeah, I mean, those surprises.
With multiple more surgeries.
Correct. Those surprises definitely can happen. And I think the challenge as a surgeon is to do the right thing, right? In those moments, you're kind of expecting and anticipating, hey, this is going to be a superficial type infection that we're going to be able to wash out and clean up and everything's going to be fine. We'll just move forward. And in this particular case, in the case you're talking about, we just tracked all the way down. And when you have bacteria and infection on metal, there's no blood flow to get rid of it. And so ultimately, especially in something that's been in an implant that's been in a shoulder or in a knee or a hip or any place for an extended period of time, that means you got to get the implant out in order to get rid of the infection. And so we had to take everything out ultimately. Take it out, antibiotics, antibiotic spacers, antibiotic beads.
They had to remove the top part of this guy's humerus.
Correct.
Like take a bone saw and cut through it and remove all of that. That was,
it was just,
and this particular person was still living a very active lifestyle.
Right.
And that's part of the reason they were in the situation they were, is they were trying to keep that level of activity up and trying some experimental stuff that ended up seeding this shoulder with infection and multiple surgeries and ultimately a poor outcome.
Right. And that's a big challenge. I mean, I think when you're, as an orthopedic surgeon, as a surgeon, as a leader, when you're trying to help, I mean, there's only so far that you can take people. There's only so far that you can continue to guide people. You can lead them where you feel like they need to go. But ultimately, a lot of this is healing yourself. It's just like a fracture, right? When we put a fracture together with a plate and screws or with a rod or with any type of fixation, ultimately what we've put in doesn't heal the fracture. The body heals itself. We're just trying to provide the stability. And so as a surgeon, as a leader, you know, that's what you're really trying to do, is you're trying to provide stability so that people can get themselves healed. In the case when you have a foreign body like a shoulder replacement or a joint replacement, you've got to get that out, because now the infection is attacking the body, it's attacking the bone, it's attacking the soft tissues in that area. So you not only do you have to get that out, you have to get all the infected tissue cleaned out, you have to now get a ton of irrigation. We say dilution is the solution to pollution, right? Dilution is the solution to pollution. So, right, you just go in and you irrigate with 6 liters, 9 liters, 12 liters of fluid. I mean, we put tons of fluid in there until you feel comfortable. And then ultimately you put antibiotic spacers or antibiotic beads. And I think in his case, we had to do multiple surgeries before we ultimately put an antibiotic spacer in that provided. An antibiotic spacer is basically a cement that's shaped like an implant, like the metal implant, but it's made of bone cement that has a bunch of antibiotics, like tons of antibiotics in it, so that we can have antibiotics leach into the soft tissues around it to try to kill any bacteria that's there. Then you come back and take that out to put the final implant in. Mm-hmm. Well, and then you still have to hope that you don't have to be on antibiotics for the rest of your life.
Well, and you can, and again, with this particular patient, it was more challenging, not just from the surgical standpoint, but also with talking to the patient and their family afterwards, because again, under the presumption that they're going to keep with a very active lifestyle that they want, and having to create expectation of, like, I mean, asking questions like, can you do a stemless shoulder replacement and stuff. And we're almost like, you're going to be lucky to ever get a shoulder replacement into this shoulder. Like you've had such massive infection and the bone is still not doing well. You're still not doing well. They had other hardware in their body because they had become septic.
Right.
Right. I mean, like there was just
infected some hardware in other extremities
but it was, I feel like that case is an example of a case that really makes you as a leader and as an orthopedic surgeon. I mean, and me being on your team, it's one that shaped me for having to have long, difficult, hard conversation with the patient, with the family, and coming up with, the roadmap to how to get that person to a semblance of where they want to be, and then the psychology behind it, right? Having to accept that, hey, this is a consequence of this infection, right? And this infection is a consequence of what? Right?
Choices that you're making.
Correct.
Right.
And like, look, you made a calculated decision, and unfortunately this time you lost that gamble, right? And though it worked for you for the decades leading up to it, here we are now. And we can't, you can't come tell me this is the implant I want put in my body. It's because I read it was the best. I'm like, yeah, it would have been.
Right.
Like it would have been a great choice for you had this not happened.
And I think it's very interesting now because this case has happened years ago, but it's very interesting now to see the influence of the internet and the influence of social media and the influence. I literally just saw within this past week an orthopedic. I mean, because people want what are we trying to do online? We're trying to get people to stay and read what you wrote or listen to what you have to say. And so, they call it a hook. You got to have a good hook. And so this particular surgeon's hook, he said, I don't care how much weight you lift with a total shoulder. You want to lift 200 pounds? Go for it. And you're like, oh, well.
Can and should.
Right. Now, is that are we being 100% totally honest in that situation? If you say, I'll let you lift 200 pounds and you don't have, you haven't gone through and you've listed what are the consequences of that, right? What are the consequences of taking a shoulder that should last hopefully 20 years and doing heavy lifting, pushing, pulling, high impact activities on that shoulder as a young person, and then ultimately seeing it altered to be a 5-year shoulder or a 2-year shoulder, right? And so, I think of my few of those in terms of shoulders where you say people have been 99%, they've been 99.99% compliant, and then they make one silly mistake, right? They lift something really heavy, or they go out and pick up a big bag of bark mulch and try to throw it over their head or something. And why they were throwing it over their head, who knows? But
they barely know.
Or there's the others who just said, "Hey, my shoulder felt so good, I just decided to swing an axe for." And I've been swinging an axe for 3 weeks, and I had to get my land cleared, and I got the land cleared, and now here I am, and I've got a periprosthetic fracture, right? Which is a fracture around the implant, right? Obviously, you know that.
Well, yeah, wink. Yeah, well, so the case we just talked about is one that I feel like is a good example of a case that again is taking that time and that effort and the energy to do the right thing for that person rather than do the simple case, but to do the more complex thing that is actually much more challenging. That's not what the patient necessarily wanted, but it was what was right for them, right? That patient wanted, hey, just take it in, clean it out, doc, and just stitch me back up and let me go back to doing the things I like to do.
Go back to riding motorcycles.
Yeah, or lifting. I just want to be able to bench 250. What?
Right.
I think that might be a quote.
It's possible.
It's possible. Maybe not 250. It might have been more. But anywho, like that's a good case to talk about, like how that separates again just the carpenter, right? Okay, I'm just gonna cut it down, release the pus, wash it out, and move on with my day. And when they end up septic back in the hospital,
right.
Knowing you didn't do everything you could. Are you not taking this podcast seriously? Do you still have your phone on, Mr. Piefer, in my class?
Apparently I do. Apparently that was my cell phone just ringing.
Just ringing away. When was the last time you had your phone not on silent?
That is an interesting question. I agree. Let me just make sure that it is on silent. It is. Now it is, I should say.
Great.
Sorry.
Well,
sorry about that, people.
Stay tuned.
So yeah, I think it's just for that particular case and for any case, doing the right thing and having the tough conversations is you don't get paid anymore for that. You don't really get anything more for that besides maybe a little bit more headache and a little bit, for me, easier to sleep at night to say, okay, I know I did the right thing because I know this guy's got the best chance to not have to come back and have 10 more surgeries or ultimately be septic or ultimately not survive.
Yeah.
And so I think that part is the challenge really for any leader, right? You've got to be able to sometimes the right road is not the easiest road, and sometimes the right path is not the widest. You have to follow the narrow path to get where you need to be.
Yeah. Okay. So now we can wrap up the talk about that case. I have another one I want to talk to you. Wrapping it up. I want to talk about another one because I think it brings up another interesting question or an interesting thing to talk about. So
here it is.
All right. So doing a distal biceps repair.
Distal biceps tendon, yes.
Right. So
super easy.
Yeah. Major incision, go down, take care of the distal biceps. There's a little more bleeding than typical. We're tourniqueted.
Yes.
And then all of a sudden there's a little bit more bleeding than typical, but we get it stabilized, close everything up, take the tourniquet down, and we couldn't get a good palpable radial pulse. And then we also couldn't get a good one on Doppler. And so making the call of, well, is that just transient? Is it from swelling? He's got a little bit of something on when we put the pulse ox on ulnar side. Like there was the question of what's the right call here of,
sure,
do we just, hey, put him in a splint, send him home, and it'll resolve? Or do we make a much more difficult call of, we're going to take you over to the hospital now to get a vascular study to make sure that we have good flow? So
I remember this case very well.
Yeah.
So as you're working around the distal biceps, so the biceps, bi stands for two, seps is heads. They all come down together into one single tendon that attaches on the forearm side or hand side of the elbow crease that you see here in the front. We make that incision. We work our way down to where the biceps is, and we locate the biceps. And then oftentimes there's just a mesh of blood vessels in that area. We call it the leash of Henry. And so we don't call it that. That's what it's actually named.
That's its given name. It's government issued identity.
It's not a friendly name that we call it. It's called the leash of Henry. And so oftentimes you have to ligate some of those vessels. You've got to move things out of the way. And in this particular case, we were under tourniquet. We ligated a few vessels, and as we attached the biceps, we released the tourniquet, and like you said, we saw some bleeding. I don't remember it being particularly just overwhelming bleeding that you would expect. Hey, man, we have had some sort of major arterial injury here.
And there wasn't that classic, for my background in vascular surgery, that classic like, whoo, whoo, whoo,
Right.
You could watch hear the pulse, the monitor, and then see it. It wasn't bright red. It wasn't anything like the classic. It was just a bit more bleeding than is typical.
And I remember that case vividly because also I was supposed to be leaving town the next day, right? And so we never did get a pulse. We actually took them over had them moved from our surgery center to the emergency room. We did a CT arteriogram, and there was an arterial injury in and around that leash of Henry. And so we ended up having to talk with vascular, go in with vascular. They went down, ultimately repaired the blood vessel, reconstituted flow to the hand. We didn't have to do anything special because we noticed it so quickly. Sometimes you have to do fasciotomies to avoid compartment syndrome, which we've talked about multiple times on this podcast, but you have to go in and release everything. But in this particular case, they got blood flow reconstituted. The patient actually ultimately did very well.
Yep.
He did amazingly well, all things considered, and had no ultimate issues from this besides having to go, instead of just going home in a splint, had to go to the hospital, had to be monitored, had to be on a blood thinner for I think probably a month, spent a couple nights in the hospital before ultimately getting to go home. But yeah, that changed how I do distal biceps tendon ruptures. Because I never use a tourniquet now. I'm always, so that I can always see the exact vessels to ensure that I've got protection where the protection needs to be. But yeah, that case, I think about that case every time I do a distal biceps.
Well, and the reason I wanted to talk about this case is that feeling when you're walking out of the operating room going, am I making the right call? Right? Because ultimately the decision of, all right, we just close him up, put a splint on and send him home, right? Versus, well, now I have to go out and tell the family that I'm concerned about this enough that I want to send him to the ER, and that's, again, you could send him and there's a big ER bill and all this stuff and there's no vascular injury. Like he was fine. It was an overcall, or there's vascular injury, at the site of the surgery that we did. And so now we've got to go through that. And so
sure, I
wanted to talk a bit more about what that feeling is when you walk out of an operating room wondering if you made the right call. Like before we knew about that for sure there had been a vascular injury in that case, what did you do with that? Like that feeling in that?
How do you sit with that?
Yeah.
I think that there's at least as a leader and as a surgeon, there's definitely a feeling, right? There's definitely this, I think in just when we make regular decisions in life, you have a conscience, right? Mm-hmm. And so most people hopefully have a conscience and you have that little voice that tells you, not only asks, are you doing the right thing, but is this, let's weigh all the odds real quick and see what if we send him home and we do have a vascular injury, how are we going to live with that, right? And not so much with what are the repercussions if you've made this huge mistake, but what's going to happen for this person, right? Because if you send somebody home with a major vascular injury, then now all of a sudden they have a functional deficit, they have potentially a limb-threatening deficit, they have potentially a life-threatening deficit. I mean, there's a million different things that could happen, and so it makes it a little bit easier if you can step back and take a breath and say, "Hey, what's coming next?" I feel like there's a voice, and we all know it when something is not quite right. Mm-hmm. And now I think that you can get tempted as a leader to block that out, to try to get done, to try to get to your vacation, to try to get where you need to be. And so you have to be cautious with that. And you have to, I think I shouldn't say maybe, I think you have to actively listen for that voice that's telling you, hey, is everything okay? And most of the time it is. Most of the time it is. But you know what? I Doppler every distal biceps. I either Doppler or feel for a pulse and make sure we've got a pulse just to be sure. And ultimately, we did the right thing here. But had we sent this person home, it could have been catastrophic because you've got a nerve block, so no blood flow. There's potential that the family doesn't recognize it. There's potential that he doesn't feel it for up to 12 to 24 hours. There's potential that once you get out of the hands of medical professionals, if nobody's looking to see if you have blood flow to your fingertips, that you've got purple fingers and somebody just says, well, he had surgery. That's why we he doesn't have blood flow. That's why he looks pale. And then all of a sudden, we're 12, 24, 48 hours in, the tourniquet goes down. He's got extreme pain. He has compartment syndrome. We have a loss of a limb or loss of function in a limb. And so ultimately in those moments when you have to make that decision, is it the right thing to do? I mean, we see that with doing things like compartment syndrome or, it's 5 p.m. and there's an open tibia fracture. And you have to ask yourself, well, if it was me, if it was my kid, what would I do? Right? Mm-hmm. You can make a pretty solid argument on a 5 p.m. open tibia fracture that you can get that done at 7 a.m. the next morning. Do we do that generally? We try not to, right? We say, listen, if this was my kid and his tibia the bone was sticking out of the skin, I would hope that the surgeon would take him to the OR and wash him out and clean it up and get him fixed. Now, that changes when you have other major trauma problems and other things. The bones don't trump everything. Right. But if you have a person who's, wrecked their dirt bike and they've got an open tibia, but otherwise they're totally fine, and it's 4 p.m., you can find literature that says you don't need to do it till 4 p.m. the next day. Mm-hmm. They just sit in the hospital waiting. And there's good arguments. You'll hear plenty of surgeons who argue that that's totally fine. Mm-hmm. But when you just sit back and say, if this was my kid, what would I want to happen?
Mm-hmm. Well, and part of what I'm hearing you talk about is it's not bad, or it's not a weakness to have a little bit of doubt.
Right.
But it is if you let it paralyze you or you sit in it, right? If you question everything and you hold on those decisions because you're doubting if it's the right call or not. Right. But just trusting, again, in, like you're saying, you're calling it your conscience, but your conscience is also formed by how many years of education and study and practice, right? That's not just a voice. That's you, right? And the knowledge and background you bring to it. And so not allowing that self-doubt to take you out, right? Right. It's okay to question yourself for a moment, but then just realize what the next right step is.
I think that, and we've talked about this before too, just taking some action, right? Mm-hmm. Like, could you have said, hey, we couldn't get a palpable pulse. We couldn't get a Dopplerable pulse. We're going to go to the PACU. We're going to watch this. We're going to see if we can get something in the next 30 minutes or in the next hour. Certainly you could make that choice. You could at least make a choice that we're going to do something that's not just, we're not going to do anything. We're just going to ignore. And ultimately from our standpoint, we basically said, we have some capillary refill. We've got some blood flow to this hand, but we're not sure what's going on. And there was a significant injury. And fortunately, we have great vascular surgeons who were able to help take care of it. And the patient did fabulous. Yeah. But yeah,
I got another scenario.
I carry that one with me.
Yeah, I got another one to talk with you about.
Yes.
Okay.
I'm ready.
So.
And I still have no clue what's coming next.
Yeah, these are all ones that I thought about beforehand, and you're just here for the ride.
This is like pickleball.
Yeah. I'm better at pickleball than you, though.
Correct. This is like pickleball except blindfolded.
Correct.
And no paddle.
Okay.
And no ball.
Okay. You good?
And no court.
I'm
good.
We done now? Okay. Yes. Okay. So.
Are we done now?
Setting the stage of another case.
Yes,
one that I can think of. Young person, traumatic injury. So we've got a femur fracture, mid-shaft femur fracture, actually kind of high femoral shaft. Okay. Vascular injury as well. Vascular called in. All right. And the family, happened to be available. And so it's, hey, this is the plan. We're going to put a rod, or an X-fix, those are the plans, is we're either going to externally fixate it or we're going to put a rod in. And vascular's going to try to do a vascular repair because they have vascular injury. And of course, like we say to everybody, there's a chance there could be amputation.
Correct.
Except in this case, there was an amputation. And so, then, again, something that in that situation, you can't spend a lot of time with like someone schedules a total knee. We can spend a lot of time talking about the different scenarios, and there's not as much time as of the essence, but we had this young man on a table already and trying to get him, taken care of. And then it ended up being an amputation because vascular couldn't reestablish any flow at all. X-fix was on, like out to length. There was no chance of a vascular repair. And so they ended up with a high AKA. remember. Is this one like coming to mind at all?
It's been a long time ago, right?
Correct. It's stuck. Yeah. Because it was the first time I can remember like dreading having to go have the conversation with the family.
Right.
About what happened. Right. Because they were expecting that their family member who had some pretty significant injuries, but, young, healthy, like we're going to go in there, they're going to get some internal hardware or external hardware, and they're going to, walk again someday and with both legs. And this is going to just be a bad story they tell people.
Right.
And in this case, ended up with a high AK.
Right. Yeah. I mean, these are anytime you have to deal with things like amputations, those are very, very difficult. They tend to be very high energy traumas. They're very high energy issues, and you've essentially exhausted every option that you can exhaust. And and when you're in that scenario, I mean, we do everything we can really to salvage the limb. And there's a whole group there's a whole group of orthopedic surgeons who are trauma specialists, who limb salvage is what they try to do. And so we always try to save everything we can. We always try to save every limb we can. But having that conversation is always a difficult one. But what the interesting part about that is that as you sort of make those decisions, and you've seen it because we do amputations. We don't do a lot of amputations, but we do some, whether they're vascular issues, infection issues, major trauma issues like this case.
Those are, and again, having the conversation about an amputation on someone who's coming into your clinic with Charcot foot or chronic infections in their leg, like this is again a conversation you can have in depth and taking more time and acknowledging. Yeah. This one was one where, I remember just thinking like, how are we going to look this person's mother in the eyes and tell her like that we did everything and this is where we're at. We got the bones out to length. We tried to clean and do everything we could to salvage the tissues, but they couldn't get reestablished blood flow.
Yeah.
And it's one of those things you dread the delivery afterwards more than you dreaded the surgery itself, right? There's no dread in the surgery, right? Like in the moment when we're keyed in and we're doing what's right for that patient. That's honestly not something that I struggle with. It was more of while closing thinking, how are we going to deliver this news to not only the family, but then later also the patient? And
I think that we're going to go for some challenging stuff. I like it.
Yeah.
I think the hard part about that and the telling part about it is trying to put yourself in their shoes, right? And to go in without compassion, without a recognition of what you have to do, of what you've had to do to try kind of blow things off, or to try to not let somebody live in that space, so to speak, and understand what's happened. And people are devastated in those scenarios, and the temptation is, because again, you don't get paid anymore one way or the other. You can sit with them for a while, or you can deliver bad news and walk away. And so I think being able to be with folks when you're having to deal with those situations, being able to provide hope and provide not only hope, but an understanding that, when you have major soft tissue trauma, you have large defects in vasculature that are not allowing us to we don't do these things. An amputation is not something that these are less than 1%, smaller than that percentage that this has to happen. And so if we're going into that type of a scenario where we're talking about this was such a substantial trauma that we've now had to have a major issue, that we ultimately are doing the right thing, because number one, we need to get this person back up and moving. Number two, we've done everything we possibly could with our team, whether it's trauma, vascular, orthopedics, plastic surgery, everybody trying to come in and get things resituated. And then finally, ultimately, we've got to move forward with an amputation, and we've got to move forward and live, right? We've got to be able to live. And so I think that part it's a message that you can deliver. You can deliver it with compassion. You can deliver it with love for the people that you're talking to, with the people who are there too. But you also don't have to sugarcoat it either, right?
Well, and that's where with it's not hard, I think, with, again, the amount of training that you have and the experience that you have to make the decision that, okay, we've exhausted all our options. This is now where we're at, and we've made the decision. But what you've talked about with the harder part and the tell of a good leader is that delivery, right? Putting yourself in their position, not just the patient, but their family, the people that surround them, and then as well as, allowing the appropriate time and giving your effort and energy to understanding and listening and all of that. That's the part that I think will separate good leaders from, because it's not something you can walk in there and be like, we had to do this.
See you later.
Yeah. Peace. Like, hey, I had no choice. His leg's gone. Bye.
And it's empathy, right? It's being empathetic.
And I say that, and it sounds weird to you and I for me to say that, but that conversation, that delivery happens.
Sure. I'm sure it does. I'm sure that it does. But I think it is. Empathy is really what you're talking about. Empathy and presence to some extent, right? We're trained to kind of separate ourselves from the emotional sides of these things to try to be able to not do that. And I think that there's power in being able to empathize with someone and understand where they're going to be sitting. And then there's also a strong sense of understanding. Because again, I talk about this a lot. I've got to be able to go to bed and sleep. I got to lay down. I'm going to have my own struggles with having to do an amputation on a young person that I've got to deal with, but I'm still going to wake up in the same place that I wake up in. I'm still going to go back to work the next day. I still have to treat the next patient because I may be on call for another 24 hours.
And so how do you do that? You've had this really difficult situation, this really difficult case, maybe one of the worst cases that you'll see, for a long time. How do you show up the next day?
Right. I think that you can, for me, that at least from where I sit, I did everything that I know that I could. I know I did everything I could. I know that I treated the family and the patient the way that I would want to be treated. I tried to will their good, and I tried to love them, and that's the best that I can do. Now, is it going to still make me feel sad when I know that we had to do this and that we had this accident? Absolutely. Is it still going to be difficult to go talk to the family for an hour about what they're going to have to deal with, and then go and talk to the patient when he wakes back up after he gets out of the ICU to say, hey, here's what we had to do? We know that those scenarios happen, and that's going to be a challenge. But I think ultimately, if you can sit back and you can look at what you've done, and you know that you did what you would have done for your own family, for your own, what you would like someone to have done for you, then for me, you can turn around and continue to work. You can continue to do what's best for the next person. I think I would be haunted more by knowing that I didn't do that, right? Saying I'm just going to blow this off and move forward, and I got more people to take care of, and ultimately, maybe in the acute moment of that, you can get through it faster. But if you're going to go through that quickly, it's going to all pile up, and it's going to catch up with you someday.
Well, and it sounds like, at least for me, some of your mental process in that is, number one, you don't dissociate, right? A lot of people will separate because it's a protective mechanism to protect their own, sanity, mental health, whatever you call it, to protect themselves. And it's not unique to surgeons, but I see it a lot in surgeons where they kind of wall that part of their life off, and they're like, I'm clocked in here now as a surgeon. I don't take that home with me. I don't. But you, after cases like that, pretty much every case, we debrief a bit. We talk about things.
What we could have done better.
Is there something else we could have done? And one thing I tell every patient that schedules with you, if I'm the one telling them about it, is like, look, the thing I can always say about him is that he does the right thing for every patient every time.
Sure.
And part of that, like you said, is just because you have to be able to lay your head on your pillow at night and go to sleep, and you won't be able to do that if there's a way. So part of it is self-protective in your way, but you choose to do that in a different way.
No doubt.
That I think makes you better.
Sure. Sure. I agree. I agree with that 100%.
Yeah. Do you think a surgeon who has never had a difficult outcome is actually a better surgeon or just less experienced? I have my thoughts on this, but I'm curious, hearing that or thinking about that prompt, if you talk to somebody, so I'm a certain thing is coming into mind. I don't have that experience, right? I'm doing this way, and my outcomes don't reflect what the literature says.
Sure.
Right?
Sure.
Sure. So if you think about that, is that surgeon really a better surgeon? Or do they just have less experience?
Or do they just have blinders?
Yeah.
So I think in reality, any surgeon who has never had a bad outcome either just doesn't operate, or there's, and when I say a bad outcome, I'm just saying an outcome that's suboptimal, right? Any surgeon who has never, who claims to have never had that is either not being honest with themselves. That's the blinders, right? They aren't looking, right? I've never had a patient who had an infection, or I've never had a patient who couldn't get their range of motion back after their total knee or their ACL. I've never had a patient who couldn't, throw a baseball after they had a total shoulder or something. Whatever, right? Whatever it is. All those are kind of silly examples, but if those are scenarios, then either you're just not following them long enough, or you haven't done enough of them to see them, because you can do everything perfect and still have an outcome that's suboptimal, and you can do everything from a technical standpoint perfectly and still have an infection and still have someone who has an unstable prosthesis, still have someone who develops a non-union, right? Who has a fracture that doesn't heal. And so to kind of, from my standpoint, you've got to be honest with yourself as a surgeon. You've got to be, if you're not always trying to get better, if you're not always trying to improve, you can't get better than never having a bad outcome, right? And
allegedly,
than never having a complication. But like, even when we go and we sit for our oral boards, we're required to mark down, these are the complications that we've had. And one of the biggest red flags that you'll get when you go to sit for your colleagues, and they're going to say, hey, are we going to certify you? Are you going to make you a board certified orthopedic surgeon? Is if you sat in front of them and you said, I've never had a bad outcome. I've never had a complication, right? I've never had acute blood loss anemia. I've never had, right? Like, come on, everybody's had those things. And so I think if you're hearing that, it's kind of like a little bit of the 5-star reviews online, right? If you're someone who has 1,000 5-star reviews, the question is, how many of those are real?
Right.
You gain, and I'm not asking for not 5-star reviews, don't get me wrong, but if every patient every time always believes that that you're the best person they've ever met, then the reality is probably your reviews are a little bit biased.
Makes me think of your friend, Dr. Lewis. I seriously don't know how to earn that 5th star. Yes. It says Dr. Lewis saved my life, and it was 4 out of 5 stars.
Oh yes.
What?
Yes. He saved my life. 4 out of 5 stars.
Yeah. So when I think of that question, one thing that comes to mind is you're not challenging yourself. You're taking chip shots every time.
Sure.
Right? That you're choosing to do such a narrow scope, and not challenging, and providing the help to people that maybe, there's definitely those surgeons out there who are like, I worked with one that was like, you need a knee replacement. I will not do it for the following reasons. Number 1, you are too young. Number 2, you are too fat. Number 3, you have diabetes. Would you like a steroid shot? And walked away. And I was like, this guy's got terrible end-stage bone on bone. He was, I want to say in his early 50s. And he was like, no, because I'm not going to risk an infection. I'm not going to risk it. And he... Sure. And again, what he was getting ready to do was sit for his boards, right?
Right.
And so he didn't want a complication.
Right.
And like you just said, okay, but you've got
tempting.
somebody who's sitting here looking at you in the office talking about how they've tried steroid injections. They've actually optimized their weight a bit. They've tried bracing. That they're just miserable. And you're just like, no, I won't help you because you're too much of a risk. So you have that. And again, the bigger thing is the blinders, right? If I don't see it, it didn't happen. It's or they went to another surgeon to fix your problem.
Right.
Just how we end up with so many second opinions here in this clinic.
We do get quite a few of those. But I mean, I agree. I certainly, if you've narrowed your practice even in that scenario, like if all you do is total knees on perfectly optimized patients every time, still the risk is somewhere in that 1 out of 100.
Right.
You know, maybe it's a little bit less, maybe it's 1 in 500, but eventually you're going to have somebody who is a perfectly optimized patient with perfect anatomy, and you've done a perfectly sterile and perfect alignment and everything is good, and they're going to come in and be like, I can't move my knee.
Yeah.
You know, or I can't, I've got an infection.
Yeah.
And you did everything. I have whatever. Yeah. And so, yeah, I think that is certainly an interesting approach. And you'll find them. You'll find folks out there.
Well, and I think that in thinking about this, what comes to my mind at least is that failure isn't necessarily always a negative thing. It can actually be a requirement to be, in my mind, a really good leader.
Sure.
Because failure is an opportunity, right? And we've talked about that before. Failure is an opportunity to learn. And so if you're blinding yourself or you're avoiding anything where you might fail, and I'm guilty of that as everybody else, very guilty of trying to avoid things where I wasn't going to get an A+, or you know, just not taking that risk, you're missing an opportunity, right? You're cutting yourself out of opportunities to help people, to get better at your craft, to learn something, to stay up to date, to challenge yourself. And you know, Wolf's Law. We get stronger and better by that challenge.
Stress makes you stronger. Stress and pressure, increased pressure makes the bone stronger. No question about that. So I agree. So very good.
Fun things to talk about today. Sorry, I was a bummer.
It wasn't a bummer. I mean, people want to hear real stuff. I don't mind talking about real stuff. I mean, I like funny stuff too, and annoying my daughter, but
those are good things to do. But some of those, thinking about some of those cases still.
Yeah. I mean, they're challenges. They're big challenges. They're big cases where you have to, but the reality is, if you look back at all of those different things, whether you're doing it in the moment, whether you're looking back in the future, and you can learn something that helps you treat the next person better and the next person better and the next person better, then that's how you become great at whatever craft that you're doing, as you continue to get there. Now, obviously, I'm not implying that you should be experimenting on things or going in unprepared or doing things willy-nilly without being prepared for what you need to do. But the reality is, as a leader, you need to be able to look back and say, this is where I could have done better. This is where we as a team could have done better. Here are the different steps that we could have optimized this situation to make this better, and a better outcome for this patient, a better outcome for the next patient, and a better outcome for everybody in the future. And ultimately, you have that power as a leader, and you have that power as a surgeon. But you also have the power as a physician assistant and nurse practitioner, a nurse in the operating room. Anybody can step up and get better wherever they are. You can do that in the operating room. You can do that in your business, right? If you feel like, hey, this is as good as it can get, then you'll be right.
Yep. Yeah.
So, but all good. Well, thanks for that, Taylor.
You're welcome.
I did push the record button.
That's great.
So that's a positive. In the world of podcasting, we're getting a little bit better.
Yeah. I'm just getting a little stronger.
Not a lot better.
That stress is really making us better.
A little bit better. People are like,
but have we gotten to 100 yet? Because when we do, Dr. Monroe has to come back on.
Oh, that's a good point.
Gotta check
probably, that. Yeah. I mean, probably people coming and going. I mean, I just get phone calls all the time. People trying to syndicate it.
Elon Musk is probably going to want to come on since he's now a trillionaire.
Is he really?
Yeah, he officially is now a trillionaire.
Well, welcome.
He's in his own class because SpaceX went
public, and he made a ton of money. Nice.
Yerp.
Yeah,
so
that'll do it.
He'll be calling us. I know he's been trying to get onto our schedule.
He's like, is there a place where I could do a podcast and get pie?
I mean, he's real efficient that way. It would make sense.
True. I mean, who wouldn't want that is the question.
What kind of pie do you think Elon Musk would want?
That's a good question. What do you think? I think he's going to be like a little bit boring. I think he's going to be apple pie.
I was thinking he would just want like 3.14, like underneath that dome right there.
You think he wants like just the number, just pie number?
Yeah.
I think he's, I mean,
maybe cherry.
I shouldn't
maybe
say boring.
cherry.
I think he's going to be traditional. I think he's going to go apple.
I think he'd do cherry.
I also think that if it was something weird, he wouldn't care. Mm-hmm. Like if it was just like,
welcome to Texas. Here's your Frito pie.
Right. I'm here.
He'd be like, is this dog food?
I like coconut carrot pie.
Wouldn't feed this to my dog.
Very nice.
Enjoy.
Well, Taylor, thank you for being here today on a Friday afternoon. Well done. Justin, thanks for being here. And I think we'll wrap it up. What do you say?
Sounds great.
Have a great week. We'll see you again next week.
See ya. Peace. Don't fall. Take your rugs out of your home.
Yes, I'm on call next week.